Dr. Derek Bruce. Dr. Derek Bruce is a professor of neurosurgery at Children's National Medical Center in Washington, D.C. I first met Dr. Bruce when he was an assistant professor at the University of Pennsylvania, and I was at the Philadelphia Children's Hospital, and he and I were always fighting about who should take care of the patient. So I tip my hat to Dr. Bruce for being willing to take over the patient totally and provide them outstanding surgical care. So welcome, Dr. Bruce. It's good to see you.
Can you hear me?
Yes.
Barely.
Thank you. Can you hear me?
Just barely.
Oh, all right. What I'm going to try to do again is cover quite a large area.
Maybe you got to pick up the phone, Derek. You might have to pick up the phone.
Okay, we'll dial back in. Is that the story? We're going to dial back in, Marty.
Okay.
Right away.
It's like surgery. You have to adjust on the fly. So we're doing fine. Appreciate everybody's attentiveness. Really excellent panel, the previous group. And what we're going to do is with this is hopefully give us a perspective on head injuries and where we are today and how we should be able to manage these kids, given that all of us, I'm sure, have very difficult times dealing with kids with severe injuries, low Glasgow Coma scores, high ISS. This is a real challenge in pediatric trauma and care for everybody. All right?
He's almost done.
Dr. Bruce is almost ready to go. We'll have this going. You know, we're looking at the Childress Institute. One of our goals is the study is to improve the research that's available for how to treat kids better. And head injury is one of the main places that we need to have that. So it's great to have Dr. Bruce here. Is the technology in line?
Dr. Bruce, go ahead.
Up to you.
Can you hear me now?
Yes, we can. Much better.
Okay, great. So we're going to try to cover quite a lot in a short time, but predominantly we're going to look at, should I be changing my slides? They don't seem to work.
We'll get that for you.
Okay, we're going to these are some of the things we're going to go over. Hang on there now. So the major thing has already been discussed, that one needs to evaluate how sick the child is from a neurological point of view. And that's increasingly difficult with early resuscitation. These kids are often intubated and ventilated and treated before we actually have a good neurological exam. And it makes, I think, comparisons very difficult. CT scan is even more important if it's available, because since we don't have an exam to follow in many of these children, we really need to follow something else, and that is something that lets us see the brain. Simple CT scan without contrast enhancement remains the most effective first study. It shows us, as on the slide that we've got here, a big epidural hematoma, shift of the brain, and on the next slide.
Derek, I think you can hit the arrow.
You can hit it, Derek.
Okay, let me try it now.
Bottom left.
Bottom left. You can back up. Back up.
Back up. So this is what they do. This is.
You can tell us. We can change it for you if you want. You can just say change, and we'll change it.
I think that might be easier, Marty, because I don't seem to be getting.
Terrific. We can do that.
I should. So on the right-hand side of this slide, then we see that the CT scan also demonstrates very well the bone, a contusion, and a small hemorrhage. Now, if CT scan is not available and you have an unconscious child, then still what we're left with is you use what's available. So plain skull X-rays are helpful in terms of looking for epidurals, because the epidural will be under the fracture line. And if one needs more, then angiography and ventriculography. And increasingly in kids, we're going to fast MRI to avoid radiation. Next slide. This is not going to... Transcranial Doppler, we've gone backwards here. This is, I seem to have no control at all about what's Let's
look at this. Pay attention to this, not that.
Transcranial Doppler, I don't think is useful in the early stages of head injury at all. It can be valuable in the ICU, but I think it's something I have rarely ever used. Next slide. The CT angiography, increasingly in those areas that have it, is replacing the use of regular angiography because it does show us vessel damage, it shows us traumatic aneurysms, shows us spasm if it's present, and you can see on the slide on the lower right a CT angiogram showing us the carotids, middle cerebral and anterior cerebral. Regular angiography, next slide, still can be helpful if one has no other access. The next slide. And this is an angiogram showing severe spasm in the anterior cerebral vessels soon after head trauma, and then an angiogram later on with good reversal of the spasm. Next slide. However, if one has CT or MRI available, there's no question that you get much more information. Here's an MRI of a child that on CT even would look fairly normal, but we see multiple white matter injuries and shearing injuries scattered through the brain, these white dots that you see. This is a child in coma, but whose ICP is likely to be normal. Next slide. ICP monitoring, as you heard, has not been shown to necessarily have an effect on outcome. But it always seems to me like I wouldn't treat blood pressure without measuring it, so why should I treat the ICP without measuring it? And the standard still is to use a ventricular catheter, as you see in the upper picture on the right, next slide, which shows us the catheter in the ventricle. The advantage of that is it also can be used for therapy and used as drainage. On the left of that picture is the other option for monitoring intracranial pressure, which is a transducer placed in the cerebral substance itself. These are reliable now, they give good measurements, but obviously have no value as a therapeutic modality. Next slide, please. The problems from intracranial monitoring are not very dramatic these days. One has to be very careful with CSF drainage that you don't collapse the ventricles and lose the pressure recordings. And an area that's still up for argument is whether the drainage should be continuous or intermittent. Also, we're increasingly finding that towards the end of the acute period, after 5 or 6 days, when ICP often will rise a second time, that the drainage of CSF then either from the head or from the lumbar spine often will help through that period. Next slide. The standard treatment of intracranial masses, and that's the reason for the CT scan, because intracranial masses should be removed. Go back. Next slide, please. The typical approach to an intracranial mass is to do what's called the craniotomy. Next slide, which is basically the removal of a flap of bone, which will later on will be replaced. And this is useful for removing epidurals, subdural hematomas. And the next slide. And is typically what's been done. Increasingly, there is a tendency to go to what's called decompressive craniectomy. This is the craniotomy back in place. The next slide, please. Decompressive craniectomies are not new. They go back for thousands of years. And the next slide. The concept is that if the intracranial pressure is high and one removes a large portion of bone and opens the dura, one will relieve the intracranial pressure. This was done by Cushing in the early part of this century and has been revived 4 or 5 different times in neurosurgical circles for the treatment of head injury. It's always lasted a year or two and then been dismissed as not being useful, or at least not being any more useful than other ways of treating the patient. The idea is that by dropping the intracranial pressure, one will improve cerebral perfusion. But one also increases end capillary pressure, and this can provoke edema, And we'll see that the amount of ICP lowering effect is relatively small. The next slide. This is the sort of thing that one should be doing if one wants to do a decompressive craniectomy, that one removes essentially half the bone on one side of the brain if there's unilateral swelling. And the next slide. Or if the swelling is bilateral, then we do a large craniotomy on the frontal part of the brain, remove the bone, and then open the dura. Next slide. The problem with this is that nearly all the studies are uncontrolled. Next slide. The importance is a large opening so that the dura can be opened widely and the brain decompressed. Next slide. And this is a picture intraoperatively of a traumatic brain where the dura has in fact been opened and we see the brain. Typically that's then covered with dura, but the dura is not sutured, and this relieves the intracranial pressure. Next slide. This really has become extremely popular in the treatment of head injury, both in adults and children. But my own feelings are, having seen this happen twice in my career already and go away, is that we're working on pretty slim basis. When do you do it? Well, one setting is when you're doing surgery acutely for subdural or intracerebral hematoma and there's severe brain swelling. The second is if in the ICU medical treatment is failing to control the ICP. But the problem, as you heard earlier, is we don't know what the ideal ICP is for children. Next slide. And therefore, it's difficult to know when the best time to do something like this is. In this side, we see a large subdural hematoma. There's been a craniectomy done, but that's far too small. The brain will herniate out there and infarct. The next slide shows us what a decompressive craniectomy should be if it's being done on one side, with a very large bony opening, so that one does one's best to avoid herniation of the brain and infarction. Next slide. The concept is that you stop brain herniation. And if you show me the next slide, what happens is the mass forces the temporal lobe down into the brain, and by decompressing, the next slide, we relieve that. So often this might help the child survive, but I think one has to understand there's very little evidence that it actually saves the brain. Next slide. And we have a couple of images coming up, one that shows diffuse brain swelling, where I think there would be a tendency, next slide, to use a decompressive craniectomy in some centers. But if you look at the results from craniectomy in children, there are a lot of complications and very little evidence that it's really helpful. This child has diffuse brain swelling, a shift from one side to the other, and therefore one could argue a decompression could be used if medical management wasn't working. The next slide shows basically a child abuse case with infarcted brain. And to do a large decompressive craniectomy here may save the child's life, but it will not save that damaged brain. The next slide. There are significant problems with this in children: epidural hematomas, hemispheric infarction. Next slide, please. And we see the results of what can happen with such a decompressive craniectomy when there's severe brain swelling, massive herniation of the brain and hemorrhage into it. And there are late problems, next slide, of subdural hemoglomas, etc. Here we see the infarcted brain, and now there needs to be a craniectomy done to put the bone back. Next slide. In general, then, the craniectomies have been shown to be useful in a trauma setting in war zones where there's a need to transport the patient from a frontline hospital to a hospital far away. May be valuable there. And in the ICU, or if one has no ICU care present, it may be possible. Next slide. I show this just simply to quickly show that ICP, while it is a problem, is not the only problem. And if you look here, children who have ICPs over 40, which is when we used to treat, yes, they have a high mortality rate of about 36%, but of those children who survived, they survived just as well as the children who had lower ICPs. So this is clearly only one factor. Next slide. Just about done, Marty. And in fact, you can skip this and go to the last slide.
One more.
I think it's two more. Next one. Next slide. And so I think that what's new, not very much, but ICP is an issue. On the other hand, it's only one factor in a whole bunch of factors. And it's unlikely that just by controlling ICP, we're going to change outcomes. And for craniectomies in children, these decompressive craniectomies, I think the indications are still questionable. The increased survival may be true, but it's probably not with necessarily better outcomes. And the long-term outcomes are poor. So I think we're still at a point where we do not have information that allows us to say that this is necessarily a beneficial addition. Thank you.
Dr. Bruce, that was wonderful description of this from a neurosurgeon who's had his feet on the ground in dealing with these patients for a long time and who's one of the forefathers and founding fathers of the study of intracerebral edema. That's just a superb description, and we really appreciate it. Our next speaker is Dr.